Welcome everyone to an In Conversation with Katy Jenks and David Marshall. My name is Emma Smith. I'm the project manager with Empowered Conversations, which is a project of Age UK Salford. Thank you, Katy and David, for giving your time today to share your work.
You're welcome.
So our plan for today is I'm going to give you a little bit of background on Empowered Conversations and the work that we do. We're going to then move over into the presentation with David and Katy, and there'll be a Q&A option at the end. We've got rain in Lanarkshire. Oh, I'm sorry, Lynn. And then we'll have a Q&A for you at the end. So as I said earlier, there's a little question mark in a speech bubble, so you can drop your questions in there at any point and we'll pick them up at the end. If you haven't been on one of these webinars before, welcome. It's something that we do on quite a regular basis. It's a hangover from COVID. We were going to do a conference. We didn't do a conference. We started doing these and we've just continued to do them with really interesting speakers. So as I said, I'm the project manager with Empowered Conversations, and we empower families to live as well as they can by keeping channels of communication and connection open. And we do that by delivering communication courses across Greater Manchester. So we deliver those to family carers and also to professionals. And within Salford, we offer dementia-focused therapeutic support through a project called Empowered Carers. So that's my bit over with. So I'm going to hand over to Katy and David. I'll just bring the presentation up for you. Okay, so I'm going to hand over to you now for the presentation, and then we'll see each other again for questions in a little while.
Thanks, Emma. Thank you, everybody, and thanks for giving us the opportunity to come along and talk for the work that Katy and I have done with 9 HC1 Care Homes in terms of improving dementia care and reducing inappropriate psychoactive medication. It's a project that involves some basic QI principles, and it's a project that involves putting the power for change to where the expertise is, the frontline staff, but we'll get onto that in a few slides' time. Okay, so I think it's probably good to start about where we were coming from, what were the issues that we were dealing with. So coming out of the acute phase of the pandemic, we were very much aware of ongoing system concerns with the prescribing and use of psychoactive medication. We had quite a few care homes that were struggling to get clinical reviews of this medication done by a prescriber. An awful lot of homes were getting stuck between GPs, services on one side, and mental health teams on the other, and nobody was actually taking responsibility to do the reviews. We also had ongoing concerns about the reliance of care staff to use medication as a frontline approach to manage stress and distress symptoms. We felt there was more that could be done in that regard. We also had some residents whose condition was a cause for concern, and an example probably would be the gentleman on the chart on screen there. So on this x-axis, what we have is time in terms of weeks, and on the y-axis, the vertical axis, we've got the number of when required antipsychotic doses, psychoactive medication doses, which is our surrogate measure of stress and distress. This was a gentleman that came into the home, and they were initially so over-sedated with the regular sedating psychoactive medication that they were actually thought to be at end of life. And when that medication was withdrawn, then the resident started to re-engage with the environment, to the point that the stress and distress behaviours were at a level such that everyone was struggling to cope, and the resident was served notice to leave the home. So we felt that the current system really wasn't serving people well, and we needed to try and change this, and no one else is going to try this, and we at least needed to try, and that involved the QI project that we set up. I'll hand over to the next slide to Katy.
Yeah, so some of the pre-project work that me and David were looking at was, did something really need to be done? We didn't want to be doing something for the sake of just doing something. And had anything been done before that we could learn from? Our big focus was improving outcomes for residents. So what we were going to do, would it have an improvement for our residents? We were seeing a lot of requests for enhanced observations coming through post-pandemic, so people needing more one-to-one care. We were seeing more over-sedation and higher use of PRN. So for us, that really indicated is, well, we need to look at something and do something. Part of that was we wanted to do it through basic QI principles, and with that, think big, start small. So we done it with 10 care homes, initially started. We finished with 8. And again, it was just about how do we improve staff confidence so that we get better outcomes for residents. And what we found through coming out of the pandemic was there was a lot of silo working. There was a lot of people working themselves, but we all had the same aim. Care homes were trying to do something, GPs were trying to do something, community mental health teams were trying to do something, but nothing was getting done because nobody was linking up. So that was one of the big first things that we had to overcome. And there was some tricky conversations at the start of, well, what you want to do, that's kind of our area, and just trying to kind of reassure everybody that we were all in it for the same outcomes. And we wanted to keep the residents at the absolute heart of everything that we were doing.
Okay, so there were certain philosophical approaches that we took. One of the first one was all teach, all learn. The belief that, you know, no one person, don't care how smart you are, has all the answers, and we really wanted to engender a community of learning. And the cohort 1, the work that we're about to show you, really did take that on board. Very much a collaborative cohort. The second philosophy was that nobody was dragged along. This was a voluntary piece. There was no mandated top down. This is the change idea that you're going to do, and here's how you're going to do it. Very much a voluntary process. People were signed up and self-referred into this program. For me, the most important philosophy, I think, was, as I said, the power was given to frontline staff. The power to change was given to where the expertise is. Homes, we recognize that every home had a different staff grouping, different resident grouping, different relationship with external healthcare professionals, different issues that we're dealing with, and it wasn't really appropriate for a one-size approach. This is what you're going to do. We were really asking homes to come up with change ideas that were relevant to their local context. But in doing that, if you're giving people the responsibility of that, you have to give them the psychological freedom and safety to challenge the norm, to come to innovate, initiate and innovate and test some change ideas, to fail, absolutely to fail, but to learn and to go again, basically, until you find out what works. And that really links into the last philosophy, which is really about thinking big and starting small. Homes were, in that traditional QI approach, homes were encouraged to start with 1 or 2 residents to see and get an idea of how good the change idea was. Things progressed towards the whole unit level, and that was great, but they really were encouraged to start with 1 or 2 residents. Obviously, our overall aim is improving dementia care, quality of life outcomes for people with dementia in care homes. We also had an aim of trying to get a 40% reduction in prescribing use of selective psychoactive medication. That doesn't mean a reduction of 40% across the board for all psychoactive medication. What it means is for residents who were part of the change idea, if they were on a when required psychoactive medication, could we get a 40% reduction from baseline? If it was a regular medication that was deemed inappropriate, could we get a 40% reduction in dose? That's what that was meaning. And sitting behind all of this really is a desire for sustainability, and that belief that actually staff ownership of practice is key. If they're coming up with the change ideas, if they're running with them, they're more likely to go with it in future, and you're more likely to get sustainability of practice of staff taking ownership of that. We also thought about how we could get this as part of a program. So we've got some of the early adopters from cohort 1 are helping us out with cohort 2. And we thought about how we can spread this in a QI way throughout HC1 as we go forward. So that's really the philosophy of our approach. Our framework of what we did is shown in this slide. So in addition to some targeted pre-work and also during the project from Katy's team, in terms of the non-pharmacological approaches to dealing with stress and distress symptoms. At learning session 1, homes were given an overview of the project in general. They were talked through some of the very basics of running a QI project, so basic QI principles. We had some previous examples from medication projects that we've run to give them some ideas and some encouragement to go forward with this. And they were also encouraged to leave the day we worked through developing a change idea relevant to each home's local context, so that they could leave the launch day with something definitive to go away and try, something practical. Action period 1 of a couple of months was really about testing those change ideas and seeing how well they worked. Learning session 2 was bringing the homes back together. It was really about cross-fertilization of ideas. And again, they really were a good collaborative group, cohort 1, and they did learn off of each other with some good examples of that. And we also had a wee discussion session about implementation of change ideas if they were at that stage. Action period 2 was really about refining and the test ideas and taking them forward. And learning session 3 was the celebration event. Throughout this whole process, the project team, Katy and I, were given sort of QI dementia medication support. There were fortnightly Teams calls. Katy did some on-site visits as appropriate, and there's some regular chart updates to encourage the teams going forward. So that's the framework and the approach. And what we're going to show you now are the results based on theme of change idea. So the first one, I think, is quite a common one. It's actually analgesia cover. So what this home wanted to test was really if analgesia cover could lead to a reduction in the use of sedating psychoactive medication. So the top chart there, again, like most of these charts, you've got on the x-axis, sorry, you've got time, and in the y-axis, you've got the number of when required sedating psychoactive medication. In this case, it's an anxiolytic. So in this resident, the home observed that regular analgesia cover, codeine in this case, led to a reduction in the use of PRN lorazepam. They had planned to actually roll this out as considering PRN analgesia before using any PRN lorazepam for this resident, but it never actually progressed beyond this stage for this resident. And they were a wee bit disillusioned at this point, probably fair to say, until we actually showed them the results throughout the whole of the unit. They hadn't actually formally rolled out this project throughout the whole unit, but something was clearly happening, because you can see the reduction there in when required psychoactive medication, anxiolytic medication in this unit. So staff are now starting to get into that process of thinking about the why for the behaviours of stress and distress behaviours and considering other approaches, in this case pain. They were starting to think pain before they actually moved forward, and they didn't always resort to PRN anxiolytics as the first line approach. This next one is one of my favourites. I really like this idea. This is born of a very sharp, observant carer who noticed that there's a resident in this care home. Their stress and distress behaviours really seem to be triggering seeing day staff leave through the front door. So they thought, well, let's test some frosted film glass over the front door to see what effect that has. And you can see on the chart there again, same setup, time on the x-axis, number of when required anxiolytics, and the PRN anxiolytics on the y-axis. You can see a 60% reduction over baseline in terms of the anxiolytic use. But not only that, there's some other knock-on effects for the resident here. They started to gain weight, which is an issue for this resident. They put on, I think it was 1.4 kilograms. They have now got a healthy BMI and a MUS score of 0, and they're just more relaxed and calmer. And staff are also thinking, well, we're not filling in as many ABC charts. This is better for us. We're saving time. We're not wasting as much time on clinical stuff or ABC chart and monitoring, that sort of stuff. So they were starting to see the benefits of changing the way that they did things. This wasn't creating more work for them, it was actually creating less work for them. So they were quite happy with that. Katy?
Yep, this one is looking at environment. So one of the non-pharmacological ones that one of the homes wanted to look at was environment. They had a lady who was in the lounge, was shouting, really vocal, really unsettled. So they started saying, well, what can we do? After a lot of conversations with the family, it became really clear that this is somebody that spent most of their time in their living room at home. So they started to recreate that, bringing in the stuff, the pictures that were always on the wall, the pictures that followed her to every single home that she went to, the cushions that she liked. The big one for me in this is one of the carers spoke to the family and says, smells. So they got the smell of the husband's perfume that he always wore. He wore it his whole life. And they went on to Etsy and got a reed diffuser of his aftershave. And I have never seen anything like this. This lady walked into the room and it was almost as if you seen her stress melting. She felt safe when she got that smell. And And this lady then, all of her antipsychotic and anxiolytic medication got discontinued because they found her why. She needed comfort, she needed reassurance, giving her that space. So they brought the familiar to the unfamiliar. She was in an unfamiliar care home, an unfamiliar room. They made it familiar. And that brought her comfort and safety. So all of her medication was stopped. Roughly 2 weeks after, she passed away. But her daughter thanked the staff for getting her mum back during that time. She wasn't sedated at the end. She was able to have conversations. She was settled. She wasn't distressed. And it follows on to that message. I always look for that why, and it is never too late. There is something going on there. But this home then, from that success, because it was very much those frontline staff, were looking and saying, what else can we do? This really worked. Is there got to be something else? So they've got another wee lounge within the community, and they thought, well, that just kind of really gets used for storage and different things, but it's got a nice setup in it. Can we turn into another smaller living space for the residents? So they done it. This room then had access to a fully secure garden, so residents could come in and out as they pleased. It had an area where they could make tea and coffee. They got the 1 cup tea maker, things like that, just for risk assessments. And they created this quiet, calm space. And as a result, you can see in this chart, they get an 89% reduction in their PRN anxiolytic use by giving people a space that they can go to if they didn't want to be in the big main lounge where it can be busy, and if they didn't want to go to their own room. And again, it shows that just looking around and look at the environment, it can have an impact. Over to you, David.
Okay, thanks. This next example is actually about personal care. It's not a medication chart, so I'll just explain the chart first of all. So again, on the x-axis you've got time, but actually what you've got on the y-axis is the number of personal care sessions per week that this resident took. So this was a resident who was struggling with twice daily personal care. The care home management, I think, deserve an awful lot of praise here, because they really took on board the philosophy that we're talking about, and they had a conversation with frontline carers to say, we're giving you the freedom to actually initiate and test some change ideas, fail, learn, try again, and that's really what they took on board. So they tried various things to try and get the resident to take some more personal care. One was desensitization to the bathroom, which really didn't have much effect. They thought, what about continuity of care staff? That seemed to have some effect. They did try gender of care staff. It didn't have any effect whatsoever. What turned out to be a highly important one for this resident was actually the height of the care staff giving the personal care, which I think is something none of us had come across before. And the outcome of this, you can see we've gone from a baseline of 2 personal care sessions a week to between 10 and 12, and that's including a reduction of regular quetiapine. So this, I think, is a really encouraging example. Again, further knock-on effects for the resident involved. This was a resident who was very much kind of sort of frightened and scared to leave the room. So excuse me. Now they're actually coming out of the room. They're taking their dinner in the dining room. They've put on some weight. I think it was like 2.25 kilograms. Again, they've now got a healthy MUS score, healthy BMI, and a MUS score of 0. And they're coming out of the shell. To the point that when Katy and I were actually home, Katy had actually left the room at one stage, and this resident came in and actually started to talk to me, a stranger to her, something she would probably never have done before, which I didn't really understand until Katy came back in the room. Do you want to finish that story, Katy?
Yeah, MD knows me. It takes a lot to make me speechless, and I was speechless. I just stood looking. This resident was sitting on the chair beside David, engaged in a conversation. And to give some context, I ran this home before, so I knew this resident really well. I had never seen her sitting down like that, so relaxed, so engaging. She'd just come into the room herself, and it just captured everything that was getting done for her, you know, that initial thing of personal care, but the impact that then had on the rest of her quality of life. So yeah, it left me absolutely speechless that day.
Hopefully not speechless for the next slide.
Yeah, this is one. This is a really interesting one. So that the resident that this home focused on had been in another couple of care homes. They'd had failed placements due to their levels of stress and distress. And they were approached and asked if this home could take them in, but they were expecting it to be a failed placement, but it was having to get done so that they could get funding for continuing care. When the resident came in, thankfully the staff were really behind. There's got to be something. My mantra on that drummer, that don't look at the behaviours, look behind. What is the person trying to tell you? Had really kicked in, and they were saying, well, that might be what they're showing us, but what are they trying to tell us? And they started delving into that. This resident's why. They were bored, they'd lack occupation, there was nothing for them to do during the day. So the staff found out things they liked. So you can see they introduced life stations so that there was independent stimulation throughout the day. She loves sitting in a library. If she ever wanted time alone, that's where her family would tell her that's where you would find her, in the library. So they recreated the library in a part of the care home for her. And they also gave her things like, you'll see the dressing table and that there. So it meant she could go up, she could take the beads away, the drawers are full of things. It gave her that meaningful occupation. On top of that, she was doing other things throughout the home during the day, helping setting tables, just keeping her busy. What most people probably class normal day-to-day life, that sometimes we forget when people come into a care home, is actually really big things. So that tailored activity plan and the life stations promoted her independence. It took that boredom away. And you can see the results here. She ended up with a 25% reduction in her risperidone, 100% reduction in stress and distress incidents, and no PRN administered. At that point, that was 4 months. I checked before coming on today and she still had no PRN administered. And thankfully, this resident now is not in the care home to get a failed placement. She's now living in her home in an environment that's supportive of her. This home took a bit of a different look when they went back and they were looking at what their issues were. They were finding that it was the reviews of medication weren't necessarily meaningful. They were a tick box. Let's get it signed by the GP to say that we've got it reviewed and we've met the policy. So they wanted to really look behind that and say, how do we make it meaningful? The staff in the home were saying they were really frustrated with the GP service, saying they're not listening to us, we want to get it reduced. But when they spoke to the GP service, they were really frustrated as well, because they were saying, well, actually, the staff aren't giving us the right information we need to be able to reduce. So they decided to come together and work together to find a solution. So again, this home took it out to the staff who do the reviews and say, well, what is the barriers? So they developed an SBAR system. And again, they developed the forum through the same QI methodology. So they're on version 4. And they used it, tried it, what needs to be different, and kept doing that process until they found one, the version that worked. What it now means is, before a review, all of the information is there that the GP needs. How many incidents of stress and distress have there been? How many PRNs have been needed? Is there any other concerns, infections, or anything that the GP needs to make that informed decision? And what both sides have now said is it's actually a lot quicker process because everything's there. And the conversations that they're having are those real meaningful conversations of, well, they've maybe been settled for 4 weeks, so let's leave it another 4 weeks and then we'll look at a reduction plan, rather than just, can we sign this box off? Their final test for that form was given it to one of their new staff nurses who just come straight from university. And it was our first care home post, and to see, could she use this system as well? Does that support her to go into the conversations? And then being able to also push back and challenge if they're thinking, well, I don't agree. This gave them the information to bring that confidence out as well. It's now resulted in the GP now reviews residents every week on their psychoactive medication with a plan for reduction. So nobody in that care home now is just on psychoactive medication and that's it. They all have a plan for reduction. And it might be that it reduces and it needs to go back up or whatever, but there's a plan in place, whereas before that wasn't there.
Okay, thanks, Katie. So this is also about medication reviews. This was a care home that was struggling to get the GP to take on board the 3-monthly medication reviews of psychoactive medication. The GP was saying to the care home, this is nothing to do with us. This is your policy. It's not our policy. We don't have to do this. The home manager was quite smart. They actually sourced the NHS board policy, which not only called for a 3-monthly review of medication, but also for a plan of reduction to put in place if at all possible. After having had that conversation with the GP practice, they came up with a way of engaging with the process and set up a process that GPs could do these reviews. And you can see on the left, the box on the left-hand side. So of 11 residents prescribed psychoactive medication at the start of the project, 8 have now had a review, and of these 8, 5 have got an active reduction plan now in place. 2 have had risperidone already discontinued, and 1's had the lorazepam discontinued. There was also knock-on effects in terms of the use of PRN psychoactive medication, which again is the graph on the right-hand side. Again, time in the x-axis, PRN use in the y-axis. So there is a reduction. We can think this is mostly down to the reviews of medication, as well as staff having training on non-pharmacological approaches to management of stress and distress. We've included this in this slide, the peak at the end, because again, things, and you're collecting data over time, things are never always going to be perfectly smooth. Things happen, and what was happening here at the end of this chart, you can see is a higher use of PRN medication, which when we looked behind that, we found this was due to higher use of agency staff to cover the October break. The agency staff were defaulting to using medication as a first line approach. Knowing that, the home can then put in place measures to then mitigate for that going forward. But again, as you can see, there was a reduction in the use of PRN psychoactive medication that's starting to come down again. Okay, next slide, Katie, please. Thank you.
I've missed it.
Oh,
I went too far, sorry.
Uh-huh.
This one was a medication review. This home was looking at a change in need. So if the resident physical health had deteriorated, they wanted to look at do they still need their psychoactive medication. Again, there was a lot of work between in that phase 2 that David spoke about at the start with this home and the home that David just spoke about, and that real cross-fertilisation ideas. This home was really struggling to get the GP on board, and she took advice from the home before, used the letters, used the policy, sent it out, so they were really engaging with each other. But what this home found really worked was, instead of just asking the GP to review everybody, let's start with one. Every time you're in the home, because the GP's in the home twice a week, we're not going to bring you 5 or 6, we're going to give you 1, and just slowly build it up and get that system in place. And what you can see here is that drop of the whole unit. That's their antipsychotic prescribing across the unit, and it's dropped by 87%. Again, like the previous slide, you've seen that wee spike. The spike here on the regular prescribing wasn't the agency when we look behind it. It was actually the clocks changing. So people were having sundowning earlier, and the staff weren't initially recognising that that's what it was. So once that was recognised, it's allowed us to put things in place, and it's something as a dementia manager in HC1 I'm looking at taking forward. That the clocks are getting ready to change, right? Let's get the homes knowing you're going to see a difference. Here's what we need to look at, and again, it's just creating that awareness around what can affect things and what can change things. This home, in the next 3 examples, they used the same process. So it was around our ABC charts that are used to look at behaviours of concern, and how could we use them to either evidence that the medication was needed or it wasn't needed, and learnt from that. And what we ended up finding was that all 3 homes had really similar results. 3 very different homes, different sized homes, different staff groups, different resident groups, different building layout. What we done in these 3 homes was we delivered a ABC information session to all staff, including domestic staff on the floor, everybody that works in that care home, so that if somebody was experiencing stress and distress, that person who's there knows how to fill it in, knows what information we need to capture, and then how to use that information to support the person to find the why. So home 1, they introduced the ABC sessions, and they were getting some improvement, but they then introduced a peer review of that ABC. So if they were thinking they had to move on to medication, the ABC chart had to be filled in, and there was a peer within the home looked at that chart just to ensure that actually have we covered everything that we know works for that resident, or is there anything that we've missed before we move on to that medication. And as you can see, the reduction of the dose. This is one of the residents within that care home. It resulted in because their PRN came right down, they'd found the why through actively using the ABC charts. The risperidone was reduced, and then the PRN was stopped. But again, like on earlier slides, what the staff really shared with us there is they thought initially, is this going to be more work? But it saved them work, because when they start looking behind at the why, they find the why, they no longer need to do these charts. They're no longer working with people that are really distressed and needing a lot more support and care. They were then able to do the stuff that we all want to do, and that real quality of life stuff and spending time. This home shows the philosophy of what we're really wanting to do with this project. So this is a home, and we thought it's really important to add this into any presentation that we do on it. This home followed the exact same as the ABCs. Initially had a really good result of a 75% reduction. The manager left the service, and this is a home that the manager was leading it. She didn't bring anybody else on board with her. And you can see there what happened was, as soon as she left, it reverted back because there wasn't that one person leading it. And for us, it's really important to show this, that it can't be one person. It's got to be everybody in that care home has got to live and breathe, so that it becomes the normal, it becomes the day-to-day. This care home, again, you can see exact same process, followed ABC charts for every dose of PRN medication. You see the spike coming down. Their 2 dementia communities get merged, so you see the spike going up. And because the staff were following that data over time, and we'll probably come on to it, but David turned us all into data geeks that we never thought we would be doing. But staff being able to see that real visual of what is going on, right, there's something there, we need to look at it again. So the staff never just accepted that actually we've merged the 2 units together, so we're having to use higher PRN. They knew at that point it was right, they needed to, while they were readjusting and finding, settling the whys, but then bringing it back down. And that was really important. A really good story with this one was I was with David in the morning doing some project work, and the home phoned me and says, Katy, can you send me all the grass through? They never explained why, and I was busy, so that's fine. Yep, emailed them through. David contacted me later on that night. The Care Inspectorate was actually in inspecting this home at that time. The home manager had the absolute cheek to go off to Disneyland and was visiting Mickey Mouse. The care staff took these charts and they spoke the inspectors through what they were doing, how they were doing it, the difference that they made. And you know, for us, that's the difference of getting that whole team involved. That manager can go away and it continues. That the resident is really at the heart of it. So some of our reflections on cohort 1, frontline staff are the absolute key to this whole process. They know the answers. They know what needs to get done out there on the floor. They don't need us to come in and tell them what their problems are, how to fix it. They just need somebody to listen and give them permission to go and try it. And like David said earlier, it is okay to fail. Everybody fails. It's what we do with that. How do we learn from it? And how do we share it with other people so that if they're going on the journey, they might know the steps not to do because we've learned there, so that they can start somewhere else. A real big part of this for us, especially coming out of the pandemic and a care home sector, was celebrating the wins, even the small wins. Care homes had a tough time during COVID, and staff were deflated. So it was about, how do we really bring them on? We're not just seeing when things go wrong, but celebrating when things go good. Co-production between HC1 and the Care Inspectorate has been absolutely invaluable in this. No one company's got all the answers. We come together and we work together for the exact same outcome, which is improving quality of life for people within the care homes. And we all learned from each other, which was great. Every time I work on this project, I learn something new. And like I says, that over time, David turned us all into data geeks. I'm a nurse betrayed. Never thought I'd be looking at data in my life. It terrified me. And then David had us sitting at night looking at data and plotting stuff, to the point that the managers in cohort 1 have asked for a session so that they can keep that up, because they've seen that actually that data, along with the stories, that's where the true power comes. And it comes for the staff on the floor as well, so they can see how things are working. Never give up and always seek the why. That is my absolute mantra in dementia care. If somebody is displaying behaviours of concern, do not look at the punching, the kicking, the hitting, whatever they're showing you. Look behind it. Are they scared? Are they hungry? Are they bored? And it's changing that culture for the staff as well, to look behind, always find what the person is telling us. Data verification. So again, it was really important when we were doing the process that the data that we were looking at was accurate, so that when we're showing graphs to other people, they're what they're saying. And that's where that co-production worked really well. So I would pull the data off of HC1 system, and David would look at it and double check it for us. We've now just launched cohort 2. And me and David were having a conversation the other week. We thought we would do cohort 1 and that would be it. But the interest in it, people coming forward, seeing the difference it's making, people have asked for a cohort 2. So cohort 2 has been launched with a plan for further cohorts. But I think what's really important about cohort 2 is the staff from cohort 1 are coming along and mentoring the staff on cohort 2. So it's that real peer-to-peer support and learning as well. The paper is just in the process of getting published in the Journal of Dementia Care as well for cohort 1.
Okay, thanks, Katie. So we're going to head towards the end by going back to where we started. So this was the gentleman that came into the care home heavily sedated, and then when the medication was withdrawn, started to re-engage with the environment, and stress and distress levels were at a point where, even despite one-to-one care, the gentleman was served notice to leave home. However, before that happened, staff followed the process that Katie's just described, the finding the why for the behaviours and trying tailored non-pharmacological approaches. So in this case, staff found that the behaviours were increased or linked to shadows in the room causing hallucinations. And also the person felt threatened by people following around the care home or sitting outside the room. So knowing that, finding the why, they could then put together a tailored therapeutic support plan. A blind was fitted to the resident's room, an alarm, a door alarm was linked to the nurse call system and implemented so the person could have safe private time in the room. And they found out what activities the gentleman liked to do, which was gardening. So this resident has gone from being served notice to leave the home. Following the process that we've done, they're now running the local gardening club in the care home. They're taking a lead daily in what they want to do. Staff are now supporting them rather than managing them. They are mobilising and eating independently, supporting themselves with personal care. They've got a better quality of life. The family have got better outcomes, so they don't have to look for another care home for their loved one. So it's a win-win all around. That was normally our last slide, but that's the end of cohort 1, or so we thought. Katie?
So a couple of weeks ago, myself and David got an email from one of the homes on cohort 1. It was actually the AD, because the home hadn't really recognised that. It just became their normal to say, look at the difference I've made in this resident. This is one of the residents. This is Joan. Joan is living with dementia and has high use of psychoactive medications to manage her behaviours. The staff automatically took the approach of, does she need these medications? Let's look and see what can go on. What can we do? How can we support her? They started looking at pain. So they started slowly bringing our psychoactive meds down, identified some behaviours of concern, but again, linked them to the times and really looking behind with those ABC charts and seeing it was pain related. So as our psychoactive meds came down, our pain relief went up. And I'm not talking about any sedative pain relief here, nothing more than 15 milligrams of codeine. So the staff worked with Joan to do that. This is Joan. This is Joan. And we really wanted to share this story. We had permission from the family to share the story as well, because they thought Joan in picture 1 was due to her dementia, that's what Joan was on her dementia journey. It wasn't. It was because she was over sedated with the medication. So because staff took that active find the why approach, she said a 75% reduction in her risperidone, 100% reduction in our venlafaxine, 100% reduction in lorazepam, and 100% reduction in diazepam. And you can see the quote there. Thank you for never giving up in Mum. We thought we lost her to dementia. Now she's back and living with her dementia. And I think that just reminds us as to why we're here, why we come and work in dementia care every day. It's not too late, and see the person behind the diagnosis, the person behind the medication, and do everything you can if we can get that medication reduced. Thank you for listening.
Oh my Lord, you did promise that the end slides would be amazing, and whoa, that was just blew me away. That picture of Joan, the before and after. Wow, what a difference it's made to her life. I was thinking, I've got a few questions, and we've got a few questions coming through, so drop your questions in there. Amanda said, absolutely love the never give up and always seek the why. Wow, Joan's story is powerful. Yeah, it was, Amanda, really powerful. And I was wondering about that injection of curiosity, the why. How easy has that been to get staff thinking like that? You know, is that just part of HC1 Scotland, or has that been like a bit of a campaign to get people curious?
So I think that's where it's about I never give up as well. I continue to seek that why. I never a couple of homes joke and say, here she comes, she's going to start asking the why. But again, it's just me showing up the same way I expect them to show up as well. That's the culture now that we are living and breathing. And as long as we don't give up, that's always we might not find the why, but as long as we do not give up, it's keep trying, because do you know what? If we don't do it and change what's out there now and find the why, who's going to do it for us? So it's about that call to action that everybody needs to do it. Everybody needs to take that ownership of look behind the behaviour. What are they telling us? Because my big thing is we might be able to use the medications and they might settle down if it's appropriate. If it's not, all we're doing is putting a mask on and they're still hungry, they're still sore, they're still scared. We do not want anybody living like that. So it's about keeping that at that forefront of, so it now is the mantra in HC1 Scotland of find the why. And as soon as they pick up the phone to me, I'll say that, what's the why? Do you know? They'll say, Kate, we've tried this, right? And it's digging deep, and it's about homes not being scared to say, we can't find the why, can somebody else help us?
Yeah, sometimes you're so close, it's hard to think, wow, what else is going on? But flipping it with, if you didn't have the why with Joan, you know, it was that why, wasn't it, that gave Joan her life back and gave her children their mum back.
Yeah. And I think we've really seen with everything, it's finding the why. It's finding the why behind it. Every single one of them had a why, whether it was height or personal care, whether it was occupation to stay busy. What do you know, that why was the driving force behind every one of them?
Love that curiosity. It's something we certainly talk about a lot at Empowered Conversations, and especially when we're supporting people with dementia, having that curiosity, because we won't always have the answers, so we've got to be curious and dig in and find the why. Right, so my next question is, permission to try, fail and learn, Is that a new approach, or are you expanding practice that's always been around?
Do we want an honest conversation? I think it's a practice that we've said has been around, but do I truly believe it's been fully there? No. I think now we've built it in because, again, going back to staff at the forefront, if you really want things to change, you need to be open and honest. And I remember at the start of this project, and I'd shared this with David before, somebody said to me, but you can't go and show everybody why we're using such high usage. And I says, well, why? Because we are using it, so we need to do something about it. And if we're not reaching out to the right people, if David doesn't know how to solve it, he might know somebody and somebody. So I think it's about changing the culture. I think part of that is society as well, about how care homes are viewed, and especially coming out of the pandemic. But we are very much moving in that direction now of it's not a blame culture. It's about let's try. What's try.
Yeah, can I expand on that just to be a wee bit fairer to HC1? I think throughout health and social care, we all say that it's okay to test something and fail something if you're using a proper approach. That's not always, what we say and what the reality is. The blame culture still sometimes, and difficult cultures sometimes exist. So I think that's across the board, and it's really just about challenging that and having that honesty to say, I don't have all the answers. I want to try something in the proper scale where there's limited risk. Try it and fail, and it's okay to fail. It's okay to, you've learned something that doesn't work, great. Let's share that. Let's move on and learn. So I don't think I think it's about starting and being honest and changing the culture across the board. And HC1 have done that through this. So, but it's not just them; it's everywhere.
It's everywhere, and it's about confidence, isn't it? Confidence to do that, and that we know that we're not. We know people have got our back. That it's okay that we're going to try this. What's the feedback from the GPs around this?
Well, you saw one of them in the slides in terms of the SBAR slide. This has made reviews of medication far more meaningful. I've now got all the information at my fingertips to make a better clinical judgment. Yeah, fantastic. I think that says it all.
Can you think of any other examples? Because obviously you'll have been working. How many care homes were in cohort 1?
So 10 started in cohort
8
1.
or 9 finished.
Yeah.
So I imagine that you'll have been working with quite a few GPs, because this is quite a change for them. Because have you not got any little stories that sort of come to mind around the GP that just was like, wow, this is.
Well, I have other stories from different projects, and it kind of links into this one. It's really about care staff having the evidence, that data over time, to then present to the GP and challenge. So I've done other projects in the past, not related to psychoactive medicines, where the care staff have had the evidence to present to the GP and say, is this what you intended for this person? And sometimes those are difficult conversations for care staff to have, to challenge GPs. But if you've got the data, if you've got that in front of you, it's sometimes really difficult to argue with that. And I think GPs generally are sensible, smart people, so they can look at that and go, yeah, actually, you know what, we do need to try and change something. They're run off their feet as well. They're going to be absolutely happy that someone's actually monitoring the medication for them. And we found that, I think, here in this project as well. I mean, when I don't want to name any homes, but when the home where the GP was not doing the 3 monthly reviews, policies now in place, and that they might be run off their feet, but they're doing it, and they're seeing the medication prescribing going down. It's better for the homes, it's better for the GPs as well.
Brilliant. I'm going to come over to some of the questions here. Oh, Katy, did you have any thoughts around GPs before we move on?
No, I just think what David said, it's really around that staff being confident now to go in. They've got the information, confident to say, well, actually, I know this resident, we found the why, we're asking for a reduction, we've spoke with the family, blah, blah, blah. Whereas without that sitting behind them, they weren't always as confident to kind of challenge that. So it's nice seeing that and the real advocacy coming through as well. And as it will save GPs money, it saves them time because the information's there, so it becomes more meaningful for everybody.
can really see the power of data in this.
Yeah.
You know, having that data. Yeah. But them owning that data, you know, the frontline staff owning that data, being confident with that data, and being able to challenge the GP and say, oh no, I think there's a different approach. So Suzanne said, have you done any training for activity and care staff on personalising care as part of this project? And did your homes have staff with time allocated specifically to occupation versus care tasks?
So I think that's part of that culture shift. So we do have wellbeing staff in the homes. All of our homes have got wellbeing teams. But again, where they were looking at that real occupation, it becoming it's everybody's responsibility and job. And again, I think probably coming for COVID as well, we were seeing a lot of activities, the big things, and it was reminding staff that the wee things make a difference. You know, setting the table, folding the towels, reading the book that they've always wanted, or getting some alone time and a hand massage. You know, it's not always about the big. So again, it's just about constantly that reassuring staff that what they're doing is right, and that this is activity and it is wellbeing, and getting them to see that as well. And that's had that impact. But that's the ethos that we are very much promoting within HC1 Dementia Care, that the minute somebody opens their eyes to go to bed, it's about that involvement in activity and engagement, and really looking at the small things that can make a difference, but also things that they can do themselves. It's not all about staff being there to do it as well. So it's looking at, is it rummage boxes? Is it the life stations that you've seen? So if somebody just wants to walk about and look and see, and that can be an activity as well.
Yeah, activity isn't just bingo. It's just living, isn't it? Basically, activity is what we all do, but we don't call it an activity.
Yeah.
When you talked about the example with the lady with the cushions and the pictures and the diffuser that had her husband's aftershave, it brought to mind Dr. Kellen Lee's work around material citizenship. So I just wanted to mention that. So that's the stuff that we all have that's really important to us, that sometimes gets overlooked, but certainly wasn't in this case. Right? There's lots of complimentary comments, excellent outcome. There's always a reason behind every action, amazing results, very impressive outcomes for individual residents. And then Suzanne said, this project demonstrates beautifully why some people's best option is to come to care. Great to see you pushing back against some of the negativity about care and lack of recognition of the specialist services they provide. Not really a question there. And then thank you, David and Katy, for sharing your fantastic work. Seeing how your work is improving people's lives through empowering staff is very inspirational. And it truly is inspirational. So talk to me about cohort 2. What's the timeline around cohort 2? So you've got, is it 7 care homes who have come to you and said, we want a bit of this now?
Yeah. So cohort 2 is 7 care homes. Following the same process, they had to want to do it. They had to ask to do it. They had to have an issue with meds. We'd done the launch day, myself and David, with some of the staff of cohort 1. And again, it was just about giving them the basic QI principles, getting them to think, what is the issues in their home, think outside the box, be curious, and go back to their homes and start engaging their frontline staff. So we're right at the early stages of cohort 2. But already we're seeing some really exciting things coming out that weren't tried in cohort 1. So one of the homes are looking at Reiki, with some already really promising results for one of the residents. And another home's looking at Namaste. One of the homes is looking about the family support, because they've identified it's actually the family that are really struggling with the diagnosis and how the person's presenting, so they're doing support there. So it's nice to see how that they've all came at very different ways as well, based on what their need of the home is. So how it will turn out at the end, I have no idea. Me and David, I don't think, thought we'd be sitting here doing this. We thought we'd be doing cohort 1 and that would be it. So it's nice seeing people getting really committed and into it, and the frontline staff really taking this on and running, and when they see that difference it's making, you see them, that they're empowered to continue it. So watch this space as cohort 2 goes, and hopefully we'll be back with you at Dementia Congress to share what cohort 2 is bringing out.
That's exciting. So you didn't think it was going to go past cohort 1. You've now got cohort 2. Obviously, I'm going to ask 2025, where are we up to? Cohort 3, cohort 4, is that the whole of Scotland covered?
So cohort 3 is already getting planned and out to start in June. We are looking to bring in some of our homes potentially in the other nations to see how would it work, what is the differences. So there's a kind of rolling plan coming along now as well, and also a plan to allow me and David to eventually step back, so that as more cohorts come up, those staff will be the ones that kind of really lead it and drive it forward, and it just becomes what we do. So again, we've been really thinking about that sustainability. We'll probably always stay in the background, because I don't know about David, but this has been the best work of my last year. It's the one thing that, you know, if I'm having one of those days where nothing's going right, I come and work in the project, because it just reminds me of why I'm here and why I'm doing the job that I'm doing. So I don't think we still want to be part of that here and sharing that innovation and inspiration that you're seeing coming from the staff out there on the floors.
Echo that. I can't add to that.
I imagine it gives you a proper battery charge, you know, like really charges you up with positivity.
I keep telling Katie that launch day we had for cohort 1, I came back absolutely buzzed to the highest level, because it was so inspirational in terms of what care staff were, the energy in the room, and it's very, very infectious. So yeah, echo what Katie said.
Well, if we have any more questions, you've got 3 minutes to quickly pop them in. Otherwise, I'm going to promote our next webinar and bring this one to an end. I mean, I love that, you know, the frosted film just on the door. Yeah, for that person. And I was then being curious about what was going on for that person. You know, how did they feel when they felt that people were leaving? They were like, well, why are they leaving? Why am I staying here? And just that so simple frosted film.
Sharp care staff recognizing that. Katie, you want to jump in there? I know there's a story behind that. I don't know if we've got time for it.
So there's a story behind that as well. So I remember my boss is coming and saying, frosted glass, fire reg, building reg, and we're saying, right, okay, but look at the difference in the person. Look at this. So we stayed true and says, no, we're not going back to chemically restraining somebody because it's coming off. So we've ended up with a change to the building regulations now, that we can put a risk assessment in place to have this for the residents if we can evidence it, which we weren't able to evidence before because it's the data that's allowed us. So when that's went to building regulations and they've seen the data, they can't argue with it. And we've got a plan in place if there's a fire or whatever, the doors are manned. But before, homes were told just to take it off because it didn't meet building regulations. So the power of data as well.
Oh, David, we finished with that comment. The power of data. The power of data. That's how we finished. I was like, what's this data? That's amazing. You know what? I think you've absolutely blown everyone's socks off. It's inspirational. It's exciting. I can't wait to find out what happens with cohort 2. And thank you so much for giving your time today to share it with us.
Thank you.
Thank you for having us.
You're very welcome. Our next webinar is an in conversation with meeting centres, and that's going to be on the 17th of April. So if you're interested, then please sign up for that. Jordan said, thank you very much. And I'm closing my book. I'm calling it a day and say thank you so much. Have a lovely Wednesday afternoon. Take care, everybody.
Bye.